off. Thank you all so much for coming. For those of you who I've not met before, I'm Joanne and I work alongside Louise in the orange top at the top in the Sport and Information team. Before we kick off, there's just a few, oh sorry, I can get a bit of feedback actually on my, anyway, before we kick off, just a few housekeeping points. Can you first of all keep your microphones on mute whilst Emma's speaking? It just cuts out on the feedback that we're going to get.
We're back out the mute button.
It's next to, it's on the bar in the middle. A little camera, then there's a microphone. Yeah, click on that. Have you got it? I think that's it, John. Yes. The next thing is we're going to be recording this webinar as well. So if you don't want your image recorded, you can turn off the camera because we'll be putting it on our YouTube channel for people who couldn't make the webinar. There will be a chance to ask Emma some questions at the end of the webinar. And the way we thought we'd do it is if you would like to ask a question, if you just put a note in the chat box, and then once Emma's finished, I'll invite you to personally ask that question to Emma. Just it makes it a bit more like a conversation. But we would ask that you keep your questions generic, really, not personal to your circumstances, just because it's not really the right forum to discuss those things at the moment. But if you do want to get in contact with Emma or Louise or myself after the webinar, you can certainly do that and discuss your own personal circumstances. I think that's it from me. So I'm just going to pass over to Louise now and she'll give you a little bit of an intro about today's speaker.
Thanks, Jo. So we're really pleased and excited to be joined by Emma Hallam today. Emma's in the white top at the top looking clinical. So Emma and her colleague Liz, who isn't here today with Emma, they're both radiographers in the NHS and have set up from scratch and run the award-winning late effects clinic at Nottingham City Hospital. So Emma and Liz have worked tirelessly to create this bespoke service to fill what they thought was a much needed gap for better support for those suffering with long-term side effects from radiotherapy and chemotherapy, a service which did not exist until Emma and Liz acknowledged how crucial it was for patients and their families to feel supported and listened to beyond treatment. So Emma, we are so pleased, honestly, to have you with us, and I'll hand over to you.
Right, hello everybody. So I'm now going to try and share my screen. Now, we did practice this last week, so let's hope it works. Okay. Bear with me a second. Okay, so that should be the, yeah, can we see the presentation? Perfect. Okay, so thank you for asking me to talk today. It has been an absolute privilege to be asked, especially by Louise and Jo, who seem so passionate to support patients like yourselves. So it's been a real privilege to work with them. So I'm going to do a bit of a talk about the late effects of treatment. I'm going to talk very much in general about how radiotherapy and chemotherapy affects patients after treatment, and then I'm going to do a little bit more focusing on what the service can offer and how we may be able to help. Okay, so we know that living a life with a history of cancer is unique for every person, but there is a common thread, and that is that life is different afterwards. Now, some patients will leave cancer behind and continue to have a life with very few or no health problems at all. And some patients will actually say that it was a real affirming phase that they went through and it helped them to reevaluate what they wanted out of life. But for others, we know that there will be ongoing physical and emotional challenges that they will experience daily for the rest of their lives. Macmillan did some work back in 2013 and surveyed 2 million people that were living with the consequences from their cancer treatment. And 40% of patients said they were unaware of any long-term side effects. Now, I know from sitting in with patients when we consent them for treatment that patients will take anything at that moment when they're told they've got cancer. They just want to be cured. So often they don't even hear the side effects. But I also know from many years ago, I'll say not that long, probably, you know, within the past 5 years, we've really worked hard at making sure patients are aware of the long-term side effects of treatment. But 10, 15 years ago, they probably weren't hardly mentioned. 78% they'd experienced a physical health problem in the last 12 months.
Emma, can I just say, I don't know if the slides are supposed to be changing, but
are they not?
No.
Oh dear.
I just wanted to, because I saw that the next slide was living with and beyond, but I don't know if I'm the only one can just see the first slide.
Oh, I don't know then.
If you clicked from beginning at the top left.
Yeah, and I'm clicking through. I've got the presentation on my top, but I'm moving through my slides now.
Joe, what can you see?
I'm the same, Louise.
I'm the same. I can just see the latest effects of cancer treatment.
Okay. Strange. Why don't you unshare your screen and then try again?
Yeah, sorry.
No, it's okay. It might have just gone sluggish or a bit slower. There we go.
There we go. That's changed.
You know what then? So does this change now then?
Yes.
Right. Okay. So I don't show. It's because I put it to slideshow, so you mustn't do that.
That's okay.
Right.
Okay.
Okay.
Sorry to interrupt. I'm sorry.
There wasn't really any nice pictures on there anyway, so we're all right. So 40% said they were living with emotional problems but hadn't sought any help. And 71% of those patients who finished 10 years ago or more had experienced a physical health problem in the last 12 months that was directly related to that treatment they had. And that, for myself and Liz, was one of the real big key things into looking at why we needed to set up this service. So the scale of the problem then, we know that 1 in 4 cancer survivors will have 1 or more treatment-related consequences that affect their quality of life. 1 to 5% of patients will have severe symptoms, and these will often need multidisciplinary team help, so that's lots of different services involved. It's a growing problem. In 2015, there were 625,000 with side effects, and by 2030, we believe that there'll be over 1 million patients living out there with these consequences. The problem we have is that these problems that patients have come with is that they're physical, they're emotional, they're practical, they're financial and spiritual. So it's a whole host of things that patients present with. It's not just one problem. And often these needs go unmet. So patients are living for many, many years with these consequences of treatment that are just never being addressed. And often patients will say, I've been cured, but at what cost? Mm. So what is a late effect then? So a late effect is a side effect that doesn't settle or a symptom that develops 6 months after treatment. The impact of this late effect can vary, and they can be minor and not affect your day-to-day at all, but others can be really troublesome and difficult to live with. And we know that the side effects, particularly those from radiotherapy, can often be very difficult to diagnose and that management can be really complex. And we also know that sometimes more damage can be done, particularly to these irradiated tissues, particularly those in the pelvis, if patients are then sent for inappropriate investigations and treatment. So it's a real complex symptoms and needs that these patients have. The other big problem we have is that how do we know it really is a late effect? You know, with the normal aging process, 3.2 million people will be suffering with urinary incontinence over the age of 65. So how do we actually know these are a late effect? So what we're trying to do now in our service here in Nottingham, and it is something that we're trying to do up and down the country as well, is to introduce real baseline scoring of patients. So we get a real, you know, not just how are you and what long-term health conditions may you have, but, you know, how is your urinary function before you even start any treatment, so we know exactly where we're starting from. So radiotherapy site late effects then, these are the unattended consequences of treatment, and they can be both physical and psychological. And again, it's this key thing, it's anything that doesn't settle or a symptom that develops after 6 months. Because until 6 months, we class these as acute effects of treatment. So these are the ones that we expect you to get. The problem with them is many can develop many years after treatment. So we see patients who develop a late effect 20 years out of treatment. And this is where it becomes a problem, because how does anybody know that then that's related to the radiotherapy treatment that they had? And what radiotherapy does, it's a bit like the gift that keeps on giving, really. Yes, we cure you of your cancer, but we cause long-term changes in these normal tissues. So radiotherapy kind of makes your tissues less stretchy over time. This is known as fibrosis. So the tissue and the muscles can become much more fibrous and rigid. And how this is affected depends on which part of the body you had treated. But this fibrosis can really affect the normal body functioning by causing this hardening and tightening and this restriction to your muscles and tissues. What I'm going to do now is just move on to the different areas of the body. So first of all, pelvic late effects. This is where a lot of the work first started, because this is where most patients were presenting with these late effects of treatment. So pelvic late effects are anything for anybody who's had any part of their pelvis treated, really. And often we see patients who've got lots of problem with their bowels. So that's often the fact patients will come and say, I can't leave the house anymore. I'm so scared that I'm going to soil myself. You know, we've had patients who've had to stop working because they literally cannot be that far from the toilet. We see a lot of patients who've got this diarrhea. We get patients who've got constipation, so they just can't evacuate the bowels anymore, and the pain and discomfort that that causes can be really quite unbelievable. And this can often be related not just to the radiotherapy late effects from having the pelvis treated, but also due to the pain relief medications that they're on as well. So it's a real host of things that come together to produce these effects. We see lots of patients with rectal bleeding, malabsorption, which is something which I'll go to on the next slide, and pain. And fistulas, again, is because we've damaged these tissues. We see lots of patients who've got lots of bladder problems, that'll be incontinence and these recurrent infections that they just can't get rid of. Sexual function, so this is where we see lots of patients with erectile dysfunction or vaginal dryness and stenosis, which can become really problematic. And also when we treat the pelvis, we can often get these really tiny hairline cracks called sacral insufficiency fractures. And they're so tiny to pick up on an x-ray that often they go undiagnosed, but can be absolutely excruciating for a patient. You can imagine patients don't only present with one of these problems, like I've said, they'll often have diarrhea and some incontinence along with this sacral pain as well. So really all these things really become a real problem and really start to really have an impact on the patient's quality of life, their relationships, and affect their ability to work. The problem with radiotherapy to any part of the bowel is we really affect the friendly bacteria that lives there. So patients will have this diarrhea that's constant, but also they will then become very malnourished. They won't be able to absorb their nutrients. They become dehydrated. So their overall well-being is really, really low in these patients and often leads to other complications. We have people who we see who've got this, it's called bile acid malabsorption. So it really affects how they are and can lead to other illnesses. So moving on to the breast chest area, we see lots of patients who get fibrosis in this area and breast shrinkage. And this is just because of how much of the area we're treating and how much of the skin and muscles are treated in this area. And this can become really quite painful for the patients as well. The pictures there just show the skin picture that you can see shows what we call telangiectasia, which is just this changing of pigmentation of the skin. And the top picture there actually shows fibrosis, whereas normally it'd be all smooth looking. You can see there the rigidity that can be seen. So we see lots of skin changes, and of course this comes with body image problems as well for the patient. Like I say, the pain's really constant, and patients then tend to find that then they don't move their arms because it hurts their ribs, and it's this vicious circle that patients keep going with. We see a lot of patients with lymphedema, but it's not the lymphedema always where it's problematic on their arm and it's actually breast and chest lymphedema, and this then contributes to pain as well. Sadly, in the past, we used to see a lot of patients who had nerve damage of their shoulder area. It's called the brachial plexus, and this can be really dysfunctioning for the patients, not to mention really painful. You know, patients literally lose the use of their arm, and there was a big problem with this many years ago. And a special interest group was set up because the patients that be damaged from having their chest area and the arm area treated. Lung and heart changes is something that we don't see as much now because we certainly plan the treatment much more accurately now. And we also do breath hold techniques to make sure that heart and lungs are out of any treatment fields for people having their breast chest area treated. But again, I still see patients presenting from 15, 20 years ago with these issues. So moving on to the head and neck area now, I would have to say personally that this is a group of patients who who I've seen in late effects clinic who've actually had the most significant changes to their quality of life. Head and neck patients very much so will get a dry mouth. And people often think that, you know, is this really a problem? I can cope with a dry mouth, I'll sign that consent form. But if you're a lecturer or a teacher or someone does lots of talking for a living, you may then not be able to carry on that job because you cannot manage to string a sentence together without needing some water. It also leads to difficulty in swallowing because we can fibrose all the or your swallowing apparatus or your muscles in your neck. Often patients will present with this, or the fact that they can't move their necks anymore. The whole neck area becomes really, we call it a woody neck, but basically the neck is so fibrosed, it doesn't move anymore. This obviously contributes to weight loss when you can't eat anymore. So it really, again, becomes these real long-term problems for these patients. We see patients whose teeth are literally going black because of this tooth decay, but this is often linked to something called osteoradionecrosis. This is where we've damaged the blood supply to the to your mandible, your lower jaw area, and this can be basically the bone just dies off. So it's really excruciating for patients who do get this again. But we are so much better at checking that your teeth are really good quality before we even start the radiotherapy now. We do see lots of patients who have hearing loss and tinnitus and balance issues. They all go hand in hand. And again, this can be really problematic for patients. If you've got a job where you have to really concentrate, if you've got this constant buzzing in your ears, you may not be able to return to work afterwards. And lymphedema, again, is something that I manage a lot of in this patient group. So just moving on to late effects of chemotherapy now. Whereas radiotherapy, literally, apart from the psychological impact and the fatigue, radiotherapy really does affect the part of the body that you treat, whereas chemotherapy, as we know, is a systemic treatment, so something that affects all over the body. So basically, you can get any side effect at all from them chemotherapy drugs. And this picture here just literally shows you the majority of the ones that we see within our clinic. The problem we have is that a lot of patients will have combination treatments. They will have radiotherapy alongside the chemotherapy or beforehand. So they often will, like I say, attend with some side effects from the chemotherapy and some from the radiotherapy, and then put surgery in there as well. You know, it can be like a Pandora's box. You never know what you're opening up really to try and sort out for these patients. So just some late effects then that I would say that, I don't mean the majority, but a lot of patients will experience regardless of where they've had their treatment or what treatment they've had. And the first one is fatigue, so tiredness, and I am going to cover that in a bit more detail afterwards. Pain is always one of our top concerns for patients that attend our service. And we have to work really hard at trying to get patients to accept why they have that pain. So often that will be explaining the treatment in detail, how it works, showing them where they had their treatment exactly on a treatment plan or a scan. Because if you can work with a patient and try and get them to explain and understand why they've got that pain, you can often find that you can get them to accept, and acceptance actually works on trying to then lower these pain thresholds that and the pain response that patients have. We also know that patients often associate that pain. So if they start to get pain 2-3 years later, their minds will then work like, well, actually, last time I had that pain was when I had my cancer diagnosis. I must have cancer again. So we have to do a lot of work around this fear of recurrence and really trying to get an understanding of why we have this pain. Body image concerns, obviously, are a big one for lots of people, particularly those patients who've had surgery. We also see a lot of patients who get this survivor's guilt. This is patients who come to me and say, Emma, I know I should feel lucky to be alive, but I just don't. I wish I'd rather have died than live like I have now. And that can be really hard. Patients who don't necessarily tell their families how they're feeling, because again, they think, oh, my family love me so much and I should be happy that I'm here, but I just feel really rubbish at how I've been left. Patients not wanting to tell the doctors and consultants how they're feeling, because they think, well, you know, again, I'm so grateful that I am here, but actually I don't want to be moaning at how I've been left. We work a lot around patients, getting them to adjust to their difficulties and try and see how can we help you live better with how you have been left. And we do a lot of work around relationship and social changes, because, you know, we do understand that it's not just the patient that goes through this, it's the whole family, and everybody has to change and adjust to this. So when I was asked to do this presentation, I thought I'd better have a good look at, you know, exactly what bone cancer late effects means to people, because we've actually only seen a handful really. So I found this paper, which is actually called Cured of Primary Bone Cancer, but at what cost? And it was a study asking patients what they felt. So I've put the on the bottom there in case someone did want to have a look at it. But what they were saying was the main problems that patients were presenting with was this functional impairments. That's often the fact that you've had radiotherapy to that area, or you've had surgery to that area, and you've got a change in your function, like your arm movement maybe, or a limb movement. Pain, like we've said. The psychosocial challenges, so how you've adapted to life afterwards, the fact that you may not have the same relationship, or you may not be able to do the same things that you did before. Fatigue, which I said I'd cover. This reduced cognitive function, which is certainly something we see a lot with patients who've had chemotherapy. So not being able to find the right words all the time, or I used to be able to remember everything, now I can't remember anything. Changes in sexuality, so again, this what we call a sexual dysfunction. I hate that term, but that's how people describe it as. Fertility issues. Now we're really lucky at Nottingham to have a really good fertility service, so we just refer straight on if we get anybody who comes in with that, but we often have to sit and talk about it. The body image changes, but also these educational challenges, the fact, you know, especially if you was treated when you was a lot younger, you know, we may have impaired you know, your cognitive function, so you can't have this, you can't retain the same information that you did before, and this may then impact on your actual job. But what I want to just address, so I'm not all doom and gloom, is this paper also stated that it was really important to understand not only these challenges, these negative challenges, but we mustn't just focus on these, because actually research shows that many cancer survivors, in addition to what I've discussed today, will find coping strategies that will give them a good life despite the limitations that they have. So just felt that was really important just to stress that, really. Okay, so moving on to our service then. So we started back in 2013, and we were really lucky to get some funding from Macmillan, because we could just see, we're seeing these patients in follow-up, you know, months, years later, and there was just no help for them whatsoever. So we are, like Louise said earlier, we're a bespoke service, and we provide advice and support to help any patient manage their physical and psychological symptoms, and to really help patients live life as full as possible after their treatment. And what's really important for us is that we are able to help you as a one-stop shop, really. And that was really important. We didn't want to say, oh yes, we need to go and see these, we need to go and see them, and have loads and loads of different appointments. So we were really lucky when we started. We approached lots of services in the hospital, and we were really lucky that they gave us lots of training, so we were able to then deal with some of the lower level issues, I would say. But also what we've also now got is that we've got like a virtual MDT within Nottingham, with all these specialties and all these consultants sat on the board. So if we've got a patient who's got a problem that we think, oh, maybe a little bit out of our scope of practice, we can refer straight on or ask for advice. And that's why we really have managed to develop this award-winning service, by working with these other team members as well. So this slide just shows you, I suppose, the majority of the things that we see patients for and deliver. So we do all the lymphedema management now for the breast patients, any head and neck problems. We deal with all bladder and bowel advice. So we actually deal with, it's called the pelvic radiation disease. So we deal with all of that. We deal a lot around sexual dysfunction, and we are actually setting up a psychosexual service for Nottingham patients. So this is where, instead of having to go and see a separate psychologist, they will just be dealt with by us in the late effects service, because we have done a lot of additional training into psychological therapies, and we can offer these at the same time as offering the practical advice. We do a lot of work around peripheral neuropathy. So this is the tingling of the hands and feet that patients can get after the nerves have been damaged with the chemotherapy, and it's trying to help patients with exercises and pain medication, and helping them to adapt that. We do all the pain management stuff now, because our pain service was decommissioned. So before they left, it was a scramble to educate me and Liz on how we could handle these patients and how we can help them the best way. And again, we do all the fatigue management as well. So that's what I'm going to move on to now. I can get my slides up. Okay, so I would say that besides pain, fatigue is the most commonly reported issue when patients come in to see us. And we know that research shows that 75% of patients after treatment will feel fatigued at some point. Now, this fatigue affects you physically and as well as emotionally, and it's described as this extreme tiredness and exhaustion, but it's different for every person. But often it's not relieved by sleep or rest. And it can be a real obstacle to normal functioning. And you only have to have one other problem that you may have and put fatigue with that as well. And you can see how that your actual, if you were to score it on a scale from 0 to 10, your actual scale is going to be going up in problem, where your problems are. And the problem with cancer-related fatigue is that it can again persist for many months or years after treatment. So when do you know that it's becoming a problem? Well, the signs and symptoms are, the emotional effects are, is when you get changes in your mood or motivation, and that you find in your concentration is poor, or your attention. Some patients will tell me that they start to withdraw from social activities, and they just start to feel a bit out of control, really, often having difficulty remembering. And people often become quite impatient, and relatives will say to me, oh, she's become really snappy and she's losing it all the time. And often it's due to this fatigue and feeling really out of control. The physical effects are that it can affect weakness of your limbs, and you really have this real lack of energy. And again, but you find that you have problems with completing daily activities. Breathlessness after you've done light activity often can be a sign, or feeling lightheaded. And actually, if you're so fatigued, you can actually have difficulty in sleeping and changes to your libido. So what can we do about fatigue then? Well, the first thing we do is we'd really sit down and have a chat about what's your daily life like, and I'd actually get you to fill a fatigue diary in. But the 3 key principles to coping with fatigue are planning, prioritising and pacing. So this is about trying to have a look at your life and how it is now, and making some small adjustments sometimes in trying to plan what you have to do, prioritising things, do I really have to do it? And sometimes it's about breaking those activities down. And we have to do a lot of work with patients, trying to get them to realise that, it's not a weakness to not be able to clean the house from top to bottom in one day anymore. We might have to split this up over 2 or 3 days, but we will work with patients to help them with this. The other big thing is exercise. It isn't on there, but we know that exercise is one of the single most important things you can do to help combat fatigue. Now, what I've put on here is a link to, it's called the Macmillan Restore project. It's actually a website that Macmillan set up. It's a tool that patients can use to help cope with fatigue, and it's actually a 4-week program. So lots of patients are telling me that it's really useful to do. So if you are suffering fatigue, that might be something that you want to have a look at and see if that's useful for you. So one thing we talk a lot about in our service is actually mindfulness. And that's because we know that by using mindfulness, we can really help to reduce stress, increase our focus, but actually really improve our physical health and well-being. Lots of pain services use mindfulness now as a way, rather than actually using medications or alongside medications. But mindfulness is about paying attention in a particular way, on purpose, to the present moment. In a non-judgmental way, and it's a way of not getting caught on automatic pilot. So it helps us to not constantly focus on the negative thoughts that we might be having. So we use this a lot in our practice. And then one thing I just want to say to you is really just try being kind to yourself, because we know that by being kind to yourself, you can actually increase our enjoyment in life, our resilience and our well-being. So this is a bit of our a bit of an ethos for our clinic, really. So just to finish, I thought you might like to see a picture of the team. So that's I'm in the middle there, and as you look at the screen, Liz is on the right and Kerry is our support worker on the left. And we just like to put a few pictures of our awards up there. So thank you for listening. Oh, just to say, sorry, that is our direct line telephone number. And also, if you have got any, if you want to email with any questions, you're more than welcome to on that email. Okay, thank you.
Thank you, Emma. Oh,
thanks, Emma. That was great. That was really good, really informative. I can't believe what you do in one place. It's just, do you know what I mean? The scope of that you cover is just huge.
Yeah.
We've got no questions at the moment, so Louise and I have actually got a few questions that we wanted to ask you.
Okay.
The first one from me is, why did you feel the need, or why did you see the need for this clinic to be set up? Because as far as I'm aware, patients who've had radiotherapy and chemotherapy have regular follow-up appointments with their oncologist, and I thought maybe some of the things that you deal with would be dealt with by them, or were you not seeing that and that's why you thought?
Well, what happens is that they will just acknowledge that it's an effect of the radiotherapy or chemo, but then don't do anything about it.
Right.
So my specialty is head and neck, and I was seeing patients in head and neck follow-up and thinking nothing's being done here for these patients. We were also getting a few referrals back into the service with people thinking they'd got recurrence when it was actually late effects of treatment, and we're talking 10, 15 years out of treatment because follow-up ends at 5 years.
Okay.
So there's a lot of patients out there in primary care that are living with these consequences and nothing is being done about it. And like I said, there was a lot of work around pelvic radiation disease, and we were like, well, surely if pelvic patients are getting these problems, other tumour sites must be as well. So that's where we got the idea from and thought, you know, we're going to run with this and see what we can do. Brilliant.
I have actually got a question here from Chloe. Chloe would like to ask you a question. If you want to unmute yourself, Chloe.
Thanks, Jo. Thanks, Emma. That was a really informative presentation, so thank you. And I know you must be super busy. I have 2 quick questions. The first one, obviously, if you're not a patient at Nottingham, can you still email on that late effects email?
Yeah, so I'm actually in the process of setting up a nationwide specialist interest group, so it'll cover the whole of the UK, so patients will be able to access where to get this local information from. We can only actually see in person patients who are either under a Nottinghamshire GP or who had their treatment in Nottingham. However, if you was to contact us direct, what I would very much do is, first of all, put you in touch with a service near you if there is one, okay? And then I would also tell you what I would do for you if I was looking after you, if that makes sense. So even if there wasn't a late effects service in your area, I would certainly be saying to you, you need to go back to your nurse specialist or your GP, and this is what I would be recommending that you were to get. It's just that I wouldn't be able to sort that out. Does that make sense?
Yeah, no, I understand. No, thank you. That's really just helpful to get the guidance sometimes, just to get in the right direction.
Yeah.
I just want to really quickly ask, for the long-term effects, fatigue is such a hard one because it can link to so much stuff. Yeah. So do you know, like 10 years post-treatment, is fatigue still a problem?
Absolutely. Yeah, it is.
Really? Like for the rest of your life?
Yes. Yeah.
Okay.
And I don't know why that is.
Yeah.
It does seem to be the longest link, thing. Okay. Yeah.
I'm like, surely, can I still use chemo as an excuse, or like, is it something else? But
I mean, our longest patient out of treatment that we've seen is 49 years, and they were still experiencing fatigue.
Wow. Okay, that's quite reassuring. Yeah.
Yeah.
And then lastly, and then I will leave. Fibrosis. Can that be irreversible, or is that one?
Sorry, I missed the first bit. So what did you say?
Fibrosis. You know about the.
Well, if you start doing some exercises, then you can certainly start to break that fibrosis down, but it will always be there. I know there are some physiotherapists who will work at trying to do some manual massage to try and break down that fibrosis. We don't have access to that, so it's not something that I ever signpost to. But I am in talks actually with another physio at the moment, who is delivering that. So I'm going to see if we have got any physios in our area that will do that. But often it's about exercise. I'm very much now trying to look at how we can prevent these late effects happening. So certainly for head and neck patients, they will all get, I've developed an exercise program now in conjunction with the lymphedema team, speech and swallow team, and the physiotherapists, an exercise program that will help to hopefully reduce this ever happening in the first place. So it's a bit like, if you've got your shoulder and you're moving it about, and then it starts to stiffen up, you stop moving it. So the more you stop moving it, the more the fibrosis builds up, so then your movement reduces even further. So it's about keeping that whole area moving and moisturising the skin as well, because the more hydrated and supple your skin is, the less chance you've got again of this fibrosis, this big woody area developing.
Yeah, good point. But no, thank you so much. That's been so helpful, and yeah, thank you for just being so passionate and involved. So yeah, thank you.
Oh, thank you, Chloe.
Can I just say, Emma, we've got another question from Andy and Jackie.
Aki.
Aki. Put my teeth back in. I think you've actually answered it a bit, but perhaps you could talk about it a bit more. It's about how do you access late effects clinics around the country? Because I know there's yours, one in Sheffield, one in Derby, and there's one in Taunton. They're the only ones that I know about.
Yeah, well, we're actually, because like I said, I'm trying to get this specialist interest group up. Myself and the Dr. Lisa Durrant, who runs the Taunton service, they just started theirs just after half. So we're kind of like the UK leaders, I'd say, in late effects. But what we're doing at the minute is currently plotting a map of the UK with all the services on there. So what I would say is if you get in contact with me, I can let you know where there's one nearby to you, how you refer to them. But like I say, I would also help you out in the meantime, even if you are going to that late effects service, because the problem is with some of the late effects services is they're site specific. So there's a lot of pelvic ones out there, but there's not ones. There's only myself, Derby, and Taunton who will see patients who do, have had their treatment anywhere, basically, no matter what part of the body or your original diagnosis was.
I suspect you're going to be very busy after this webinar.
That's all right. That's what we want to be, because we're busy, that's why we're here, is to help patients. I get so infuriated when a patient comes to me and says, why wasn't I referred years ago? And you look back at their notes and it's documented, struggling with this, that'll be the radiotherapy, but nothing was ever done about it.
Yeah, no, it's great. It's fantastic that you're so passionate about it. I've got another question, if that's okay. I know that you're a radiographer and so's Liz, and I know Derby, that clinic's led by radiographers as well. Why is it so important that it's radiographers that lead these clinics, not a nurse or a physiotherapist or whatever?
So the reason why is because we know radiotherapy.
Right.
So we understand radiotherapy, and like I alluded to in the presentation, we can get your treatment plan out, we can get your old scans out, your actual treatment plan, and show you the actual treatment area. I mean, if I just go back here on this slide to the pelvis one, just for example. So this here, I mean, this is actually a gynecological patient, but you can see there. So basically the red area that you can see there, that's the actual high dose area, but you can see all that blue area has all had radiation to it. So if you had got a bowel problem, we'd be able to say to you, this part of your bowel was irradiated, this is the small part of your bowel, and this is responsible for this, and this is why you've got that. And if you can really help to show a patient and get them to understand why they've got this problem, they start to accept it. And we know that we are lowering people's pain scores and improving their quality of life just by giving them acceptance and understanding. When we first started out, we used to go, me and Liz used to sit there and go, oh, we haven't really done anything. We've only sat and talked to them. And all these patients were coming back saying, oh my word, you've changed our lives. We can see, you're just changing everything. You've made us understand. You've given us light at the end of the tunnel. And we're thinking, we haven't really done anything. So actually, it's about having that understanding. And the one thing that we do is give time as well. I'm not saying any other profession wouldn't do that. I'm sure they would if they were in a service like this. But it's about having that understanding with the time and the skills. And like I say, the skills, I'm not a physio, I'm not a dietitian, but we have done lots of extra training to be able to, to deliver this service.
Yeah, I think we've said before, and I think you've said this as well, being a one-stop service, that's really appealing to people.
Yeah.
That they can come to you and you can help them with lots of things rather than coming to you and then they have to go and see somebody else about another problem or whatever. So
I mean, we do referrals on, absolutely we do. And if a patient needs an intense physio course, we do refer to the physiotherapy team, but we refer it telling them exactly what they need. So even the physiotherapists have then got a real understanding of, well, this patient's had this and this bit irradiated, so therefore we need to be mindful of this but work on this. So
yeah. I think you had a question, didn't you, Lou?
Yeah, but I've just seen John's posted something. John Bradshaw. John, do you want to ask your question before me?
Yeah, can do, yeah.
Go for it.
Basically, from what you've just been saying about going back and looking at old records, my treatment was done 40 years ago in Sheffield. Yeah. Are they likely to still have my records?
Yes, they will. Yes, they will. Yes, and so we have all our treatments are archived. So I'm sure Sheffield's will be exactly the same. Okay. Exactly the same.
Yes. I'm trying to get a referral to the clinic, but I was supposed to go for a circulation test on my legs, lower legs, a brachial test or something. And my GP won't refer me till I've had that done, and of course it's cancelled with COVID.
Yeah.
I think it's the peripheral neuropathy issue, to be honest, not circulation.
Yeah, absolutely.
I can't go until I've had that test. So.
Right.
Yeah. But yeah, they will. So most, and the thing as well is treatments are actually pretty standard within radiotherapy. So, you probably got some tattoos somewhere from your treatment that you had. So often we can, so a lot of, when we mark patients for treatment, a lot of the time patients will have little permanent tattoo marks.
No, mine was
so we can actually, Sorry?
One was my leg, so it was just.
Yeah, so a lot of the time, our patients will have, whether it be a limb, whatever is treated. But yeah, so there will be an official record of your treatment and the actual field size that it was. Yeah.
Okay. I think John's also asked if we can have a copy of your slides, Emma.
Yeah, fine, yeah.
By the way, really good.
Yeah, that'd be great.
Yeah.
We've also got a question from Elizabeth. Would you like to ask your question, Elizabeth, or do you want me to put it to Emma?
Hi, I finished chemotherapy in 1986, and I would just like to know statistics of how likely I am to get various things, because I go for heart scans every couple of years, and I've got lots of problems, but how likely am I to get some of the other ones?
Well, again, it varies really. It varies on to what type of chemotherapy that you had. But I mean, you're quite a way out now, aren't you, already?
Yeah.
Yeah. So again, you can't always put statistics on these things because everybody is so different.
Yeah, it's just I wondered if there was a join the dots bit of the country, you know, where they see how many people so many years on have got.
The problem is they're not reported. This is the problem, because a lot of the time you're discharged at 5 years out of treatment, follow-ups for 5 years. So this is not recorded. And this is what we're saying, is all these patients out there living with these late effects, but nobody knows about them. Yeah. Because until a patient comes forward. So certainly myself and Lisa Durrant, and obviously and Liz, what we want to do going forward is we want a national database of late effects, but it's only going to be those patients who come forward. We have a record, you know, we keep a record of all our late effects patients, but what they concentrate so much is on this acute toxicity, so that within that first 6 months, and then that follow-ups for 5 years. We know now that patients are being discharged at 1-2 years. So, you know, I mean, don't get me wrong, I'm not saying that's for bone cancer patients, but certainly for prostate patients and gynae patients, they're all discharged at a year now. So there's going to be more patients, which is why these digital proms, which I'm working on, these patient reported outcome measures. So all my head and neck patients will be filling a digital prom in every year for the rest of their lives, because we just don't know when these late effects are going to start. And that's the issue.
Yeah.
Does that help a little bit, Elizabeth?
Yeah, thanks. I just I've ended up with things like osteoporosis and
yeah, absolutely. So all the, I mean, I don't know where you live, or even if you've got access to a late effect service, but you could always have a chat with us, and we could say, well, these are the things that you may possibly get. I'm not saying you would, but these are the things that we would, if you were going to have late effects, and all of them, this is what you could maybe look out for, if that made sense. We'd certainly be able to do that for you.
Oh, thank you.
Yeah.
Thanks.
Shall I go? So I just wanted to know how it worked for children and teenagers who have come out of treatment and maybe are that bit younger, so they're not sure, you know, kind of how they're going to grow, or, you know, puberty and changes like that. How do the late effects clinics fit in with those types of patients?
So normally those patients are followed up, well, in some centres they're followed up for life by the actual paediatric teams. Others will move into what we call the TYA service, that's the Teenage and Young Adult Service. I was in Nottingham, wanted to then discharge those patients to under our care, but we don't keep patients. We see you, we address your needs, we try and give you some self-management, we follow you up once, twice, but then you have to get back in touch, because we can't keep all these patients under us, unless you've got an actual need. So patients will be just signposted to this, you know, this is this late effects service, you contact them if you've got a problem, but knowing that they're told these are the late effects that you may potentially get over the next 10-20 years or whatever.
Okay, no, that's interesting, thank you. And oh, Chloe, would you like to, sorry, go on, ask your question if you want to.
Sorry, I'm back again.
No, it's good.
How easy is it for patients to request their hospital records and like every scan they've ever had done?
Yeah, you can do. Yeah, absolutely. Every trust will be different, but with ours, there's something you have to write to or email to, and then you can get all your records. I mean, if we have somebody come who had their treatment, who was under a Nottingham GP but was treated, let's say, at the Marsden down in London, we would get all access to that.
Oh, really?
So
yeah,
would get that, but you as a patient can get a request to all your medical records.
And you can get like everything. Is there any restrictions?
Well,
to what?
I don't know if you get your scans, but you may just get the reports of your scans. I don't know. So
okay, I'll look into it. Okay, thank you.
I was going to ask as well, Emma, how it worked for, or how it might work in the future for people who have late effects from surgery. I don't know if there were any plans or any discussions that have been had around that yet.
No, I mean, certainly it wouldn't be something that I would cover, just surgery, because obviously my scope of practice is a radiographer.
Yeah, of course.
However, obviously there is is also some nurse-led clinics that are setting up, and I would imagine that they would very much cover the surgery. Obviously, if you've had surgery and radiotherapy and chemotherapy, absolutely you can be seen in our service. Okay. But there has to be a cut-off, I suppose, at some point.
Yeah, sure. Yeah, absolutely. Okay.
I think Louise and I were both interested as well in the psychological issues, because you deal with that as well, your psychological late effects.
Yeah.
Yeah, you know, if you've got somebody who comes to you who's suffering, you can help them, point them in the right direction.
And that's because there's such a lack of psychologists, really. We had no access to psychology support at all at first. We have in one of our hospitals now. And we did it's called level 2 training, so it's extra training that you get if you're like a nurse specialist or in these specialist roles. But then we've had lots of add-on training, so we've done lots of cognitive behavioural therapy, lots of mindfulness, lots of goal setting, lots of problem solving, pain acceptance, because actually it doesn't matter who's delivering that psychological intervention. It's about having the person who, it's about having that therapeutic relationship, really. And that's why it works so well in our service, because they get the psychological interventions alongside the practical help. Yeah. Don't get me wrong, we still refer to our local IAP services, and we do use our Maggie Centre. And we on the mindfulness app link, I forgot to tell you that on the mindfulness page there that I've done. The Valindra Centre in Wales have actually set up a mindfulness app for Macmillan, and it's fantastic. So there's a link there for Apple devices and one for Android, and it is a really good introduction to mindfulness and some mindfulness techniques and practices that people might find useful. But it's a really good one. I know it's a really safe space to be as well.
Okay, thank you. That's really good.
I think I've got one last question, and then I will leave you alone. And it's just, you said that other late effect clinics are going to be set up around the country. You're in the process of putting together like a map that they can follow about how to do it. Yeah. Whereabouts is likely to be the next? Because there's not that many at the moment, is there?
I think we've got about 12 on the list now. But you see, the problem is they're in the process of setting up.
Right.
So the problem is they've got to obtain funding. They've got to get training. I mean, it took us a year to get funding, a year to get our training before we saw any patients.
Wow.
So so they're up and down, the country. But we are setting up guidelines for radiographers to set up the service. But then again, we have lots of nurses that all speak to us as well as saying, what training did you have? What do you do? What do you see? How many of this do you see? What do you do with this patient? But also what we really want to do is, myself and Lisa and Liz, we want to develop this kind of virtual MDT, really, where professionals can link into us and ask for our expert help, because we've been doing this for a long time now.
Yeah.
So yeah.
And it obviously works. Yeah. And so it's, follow this model that already works. So really what you're saying is a couple of years down the line, there'll be a lot more out there.
Yeah, it's also part of the radiotherapy service specification now that we have to be asking questions about late effects and how following the patients up, but they've not quite said when and how that should be done. Right. So you could ask that question at the end of treatment. Well, they're probably going to have acute effects then, so it's a bit, but they are saying that patients should have access to late effect services. Yeah. It's a growing field and a growing area.
Yes,
and much needed, I think. Much needed. So no, that's great. Well, I think that's it. I think I've certainly exhausted all my questions.
Was there anything else that anybody wanted to touch upon or to ask Emma about? You can always drop us an email or drop Emma an email afterwards if there's something that comes to you.
Yeah.
No, that's been really, really good. We're a bit early, but that's no bad thing.
Would it be possible?
Yeah, sorry.
Oh, sorry, this is Gemma. I'm an occupational therapist at University College Hospital in London.
Oh, hi, Gemma. Hi.
I wondered if I could ask a question. Sorry, I didn't know how I was supposed to kind of text it in or something.
Oh, sorry, Gemma, you joined after my little intro, so sorry about that. Yeah.
Yeah, sorry, that was my fault. I probably was logging in. But Emma, that was really, really interesting. And with my physio colleague who's also attending this today, we work with quite a lot of late effects patients. And my question really to you was, I wondered how often you see patients presenting with kind of cognitive late effects, or cognition that's a problem in relation to fatigue. Is that something you see a lot?
I'd say probably 90% of our patients who come to the service, if I'm honest.
Oh, wow.
Yeah. And that's also due to, if they've had chemotherapy, they will have this, a lot of them have this chemo brain, this chemo fog, which we know is a recognised condition now. But yeah, absolutely. And also, there's just the fact that they've got these late effects, that itself is exhausting in its own right, that they've got a late effect of treatment. So once you've sometimes got over the fact that it isn't actually recurrent and it's nothing to worry about from that point of view, that's exhausting. So yeah, I would say 90% of patients come with some altered cognitive and certainly fatigue.
Yeah, okay, that's really interesting, because that's kind of my experience as well. And those things, obviously in terms of work and study and stuff like that, it's a real problem for people. So it's really good to hear your perspective. I'm really interested in that. Thank you.
Thanks, Gemma. Okay. If there's no more questions at the moment, we can leave it there. Thank you all again for joining us. We wanted to remind you of our next webinar, which will be 2 weeks today. And we'll be joined by Mark Reed, who is a specialist radiographer at the Proton Beam Therapy Centre in Manchester at the Christie. And he's going to be talking to us a little bit about what proton beam therapy is and how it basically works for the primary bone cancer community of patients. So I hope you can join us for that one.
Yeah, so I think really all that's left for Louise and I to do is just to say a massive thank you to Emma for that fantastic presentation. It was so useful, and I'm sure everybody's learnt a lot. And yeah, and thank you all for joining us, and hopefully we'll see you at our future webinars coming up. Okay, bye everybody.